everyone, welcome to Mindray high-sensitivity cardiac troponin I and NT-proBNP assays online launch event. As we know, cardiovascular diseases are the leading cause of the global mortality and a major contributor to disability. It is reported that cardiovascular disease deaths accounted for 32% of all global deaths, with more than 3/4 of those occurring in low and middle-income countries. Detecting cardiovascular disease as early as possible is crucial in order to initiate management with counseling and medication. In such scenarios, serum testing of cardiac biomarkers is a widely used approach for the timely diagnosis and comprehensive management of cardiovascular diseases. Now, you must be curious about the significance of undergoing serological tests. Today, we have the privilege of inviting two esteemed experts in the field of cardiovascular health who will share valuable insights on the clinical applications and importance of cardiac biomarkers in relation to cardiovascular diseases. Our first speaker is Professor Damien Grusson, the head of the Department of Clinical Biochemistry at Clinique Universitaire Saint-Luc. He will be sharing his observations on the expectations of cardiological clinicians regarding the use of cardiac biomarkers in the diagnosis and treatment of cardiovascular diseases.
Hello, very good morning. I am really happy to be part of this online launch event focusing on cardiac biomarker. My lecture today will have a focus on heart failure, the value of biomarkers, more specifically natriuretic peptides, and how we can use this biomarker for diagnosis and prevention of heart failure. And my name is Damien Grusson. I would like to thank Mindray for kindly organizing this educational activity. I have to state also some unofficial declaration of interest. I am completely addicted to chocolate, specifically the Belgian chocolate, the dark one. Also really in love with the Belgian dance music, and we can take the example of lost frequencies, and to admit also that I am a football fan, Paris Saint-Germain, Kylian Mbappé, and relying on this chocolate music sports to distress in our context of healthcare, which can be a bit challenging from time to time. Here is my workplace. In the middle, the hospital, and in gray light, the labs. The Department of Laboratory Medicine include anatomopathology, biochemistry, hematology, microbiology, and molecular medicine. We have about 12,000 square meters focusing on these lab specialties with around 300 workers. We are located in Brussels. So if you are visiting Brussels, let me know. I will be happy to show you our facilities and to advise you to some good place to see, like the Atomium or some windmill close to the hospital. Cardiac disease is one of the major problems worldwide. The risk of having a death from cardiac disease is clearly more important than taking the plane. I like this provocative picture from the World Heart Federation. There is an increase of some risk factor. There is the traditional risk factor like high blood pressure, lipids, obesity, smoking, and the WHF is really active fighter against smoking, and clearly new factors like the air pollution, and air pollution is clearly related to an increased risk of cardiovascular disorders. So the call of action for more sustainable practices in laboratory medicine, working in smart cities, fighting this burden is really up to date. If we are now zooming more on heart failure is defined as a global pandemic. The prevalence is still expected to rise. Mortality remains high, even the progress of the treatment. And beside this high mortality, high morbidity, and you can see in the picture that the mortality, 1 year mortality is around 15 to 30%. If you go to 5 years, we are higher than 50%. But it's also a disease which is really a burden in terms of cost to the healthcare system. Millions of euros, billion over the world are related to heart failure. The patients with heart failure are also known to have long stay in the hospitals. You see in this recent publication that the median for the length of stay is around 12 days. And one of the objectives of the modern healthcare system is to reduce the length of stay and provide more support for home care. So we are, with our laboratory test, important player to estimate patients who can benefit for shorter stay or candidates to return to home. So, if you are spending less time in the hospital, you are clearly at a lower risk of nosocomial infection, and the cost of the stay will decrease. Back to the epidemiology, in terms of numbers, more than 56 million individuals worldwide. The adults older than 70 years are the more prevalent, and a focus on the low to middle income countries, representing 69% of the case, meaning that we need also to have a solution that could be accessible for those countries. If you look to this figure, we clearly see that there were a global trend of the reduction of the mortality, but over the last years, the curve still start again increasing because there is new etiologies that are leading to this increase of mortality. So we need to keep work on new treatment to still try to decrease this mortality of heart failure. There is different symptoms that could be related to heart failure. The dyspnea is one of the common symptoms, but dyspnea is not symptomatic or specific, to the heart failure. Other cause of dyspnea could include pneumonia, pulmonary embolism. So the differential diagnosis is important. Other symptoms of heart failure can include edema, intestinal or lung congestion. So you have a syndrome with multiple symptoms characterizing this heart failure patient. And according to the increase of the heart failure severity, the capacity of exercise is clearly reducing. We have a universal definition of heart failure now, including these symptoms and signs, including also the structural and functional cardiac abnormality, and corroborated by also a laboratory tests. The champion in that case is the increase of natriuretic peptide levels. So like for the myocardial infarction, we have biomarkers in top position for the definition of heart failure, or the objective evidence of a cardiogenic pulmonary or systemic congestion. We can rely on this universal definition of heart failure and biomarker to try to do the right diagnosis. One of the hallmarks of heart failure is also the neurohormonal activation. So in response to the failing myocardium, different systems will activate and release compound that will act to decrease the load of the heart, to decrease the vasoconstriction, and so on. That's the case of natriuretic peptides. That's the case of the sympathetic nervous systems, or the renin, angiotensin, aldosterone. So we have different systems that activate, and we can monitor the level of activation of those systems by measuring the related biomarkers. That means that the heart is also considered as an endocrine organ with the capacity to produce or synthesize compounds to face some decrease of function. It was early evidence by electronic microscopy by Jamieson in Palade in 1962, where they observed secretion granule in the cardiomyocyte. Later on, Debold and colleagues showed that this atrial extract, were pharmacologically active by producing natriuresis and diuresis in rats. So they named this compound natriuretic agents, and later on leading to the characterization of the natriuretic peptide family. First, identify in the heart as pharmacological active compound. Isoforms were found in the brain, so the name brain natriuretic peptide came, and later the main site of production of BNP was confirmed to be the ventricles. So the cardiomyocyte in the ventricle, in response to a mechanical stress, will synthesize the pre-proBNP, which will go for the processing to proBNP, and add the cardiomyocyte membrane to the fragments, the cyclic biologically active BNP, around 32 amino acids, and the linear NT-proBNP, biologically inactive. There is a family of natriuretic peptide with this common denominator of a cyclic ring that could fix to the receptors and lead to the biological effect of the natriuretic peptides. We have the atrial natriuretic peptides, the BNP. There is also an example like the C type, which is more related to the endothelium or the kidney. So a family with a common denominator, the cyclic ring. The activation and the effects are led through the cGMP as an intracellular mediators. The effects will be on different tissues or organs like the heart, blood vessels, kidney or adrenals, but also include effects on the adipose tissue. Extremely performant biomarker. We saw that in the definition of heart failure, and it's clearly top position in the guidelines, even in the European Society Guidelines of Cardiology, where you can find NT-proBNP and BNP for the diagnosis algorithm of heart failure. Same in the guidelines from the American Heart Association, American College of Cardiology, Heart Failure Society of America joint guidelines, where it's in recommendation class 1, mentioning that in patient presenting with dyspnea, measurement of natriuretic peptide is really useful to the support of diagnosis or exclusion of heart failure. So high value for the diagnosis of heart failure. What is also interesting is the dynamic of these natriuretic peptides. In acute state of heart failure or failing myocardium, we have high production, high concentration, that's the peak. And if you are treating efficiently the patient, if you are deconditioning, we have a decrease, a fall occurring within the hospitalization. So we have the case of the patient in acute episode with high concentration circulating, and the case of stable status or decongestion where the concentration will be clearly low. So we have a dynamic range of concentration reflecting the evolution, progression, or stabilization of the disease. The guidelines also include different decision limits, and we need to be careful in effectively adjust the decision limit to the different population. That's true for the different compound, and maybe a bit more pronounced for the N-terminal fragment, even it could be the NT-proBNP or from time to time mid-regional pro-ANP. Recently, the natriuretic peptides was demonstrated as effective companion to determine the patient who were needing a high intensity of care for the heart failure. That was a strong HF trial, and according to the baseline and delta change of NT-proBNP, the good responder were identified. So multiple evidence in terms of diagnosis, multiple evidence in terms of management of the treatment, so with benefit in terms of reduction of hospitalization, reduction of admission to the intensive care unit or to the cardiology, decrease of the length of stay, leading to the call of action from the ESC, Peptide for Life, ensuring that the awareness is raised. The accessibility of the testing is also possible all over Europe, and we want to expand to the world. So the value of this natriuretic peptide testing is multiple. We have the clinical value, as I showed. There is the value for patient. Knowing the value or the interest of the test, they can better understand why it was prescribed and how they can empower the control of the disease. We have the operational value, where we have no evolution of the test, which were automatized, and we have very consolidated automated solution providing the consolidation of the cardiac biomarker panel with short turnaround time of analysis. So we are able to respond to the clinical expectation of the physician who want to have the results fast. There is also, the economical value of the natriuretic peptide testing. There is multiple international studies showing that the use of natriuretic peptide is related to a decreased cost impact for the hospital and for the society. So in an health technology assessment process, you have multiple arguments to push the use of the natriuretic peptide testing in your country or in your institution. Those natriuretic peptides are unfortunately not perfect, and there is clearly no lab tests that are perfect. We need to adjust the decision limit according to the gender, according to the age, according to the BMI. There is other cases that include the specificity of the assay or the biological variability, and let's dive a bit in some confounding factors. According to the assay format, you need to take care of the impact of the hemolysis or the potential interference with biotin, and there is guidance like this one from the IFCC showing the sensitivity to interference like hemolysis or biotin for the different assays. So you can use it if you want to have a first estimation before selecting your method. The specificity matters. Indeed, it's not as simple as having BNP and NT-proBNP. There are multiple circulating forms, fragments like the BNP 532, 332. There is the precursor, which is also circulating in the bloodstream. And for the NT-proBNP, there is different level of glycosylation. The assays BNP or NT-proBNP are cross-reacting with the precursors. The NT-proBNP assays could be influenced by this state of glycosylation. Altogether, this phenomenon explains that you have high intermethod variability and that it's recommended when you are monitoring a specific patient to keep using the same method. The other consequences is clear. We still need to standardize, and there is effort for the scientific society, so for the standardization of both BNP and NT-proBNP assays. High variability, high diurnal variation for the natriuretic peptides, leading at the end of the day to high also biological variability. So it's clearly established, and it's one of the examples that you have a high reference change value for the natriuretic peptides, even BNP or NT-proBNP of more than 70%. That need to be considered if you want to determine significant change when you are doing patient follow-up or a serial measurement. So that was some confounding factors. We have also additional opportunity or perspective by a better understanding of the chemistry of those peptides, leading to therapeutical perspective. By modulating the length or some amino acids on the cyclic ring, we can modulate the acting effect of the natriuretic peptide. So there is, like for insulin, some new analogs that can be used for the treatment of patients with heart failure and which are subject of research. So we have value of natriuretic peptides for the diagnosis, for the monitoring of heart failure patient. One of other issue for heart failure is how to get the most personalized care and subphenotyping of the patient. We can use different assays. There is an issue in patients with heart failure, which is iron deficiency, very common. More than 50% of the patients with heart failure are suffering of iron deficiency. So this phenotype of HF patient with ID need to be identified and treated because there is the prognosis, which is bad, related to this iron deficiency. So the patient have a high risk of adverse event if they are showing iron deficiency. Because of what? Because of multiple impact in this HF patient, amplifying the heart consequences, but also having impact on skeletal muscle function, kidney function, and metabolism, so leading to lower exercise tolerance, lower quality of life, and an increased risk of hospitalization. There is different kind of the of iron deficiency in heart failure, the absolute deficiency or the deficiency by sequestration in the cells related to the inflammation or inflammatory context of the patient with heart failure. That's why, as laboratory, we have the need to provide the right decision limit or the right guidance to detect this iron deficiency. So for the absolute iron deficiency, clearly could be staged if the serum ferritin levels are below 100 milligram per liter, or if you suspect an ID in the context of inflammation, you will need the conjugation between the serum ferritin between 100 and 299 milligram per liter and transferrin saturation level below 20%, which will highlight the functional iron deficiency. There is novel opportunities from emerging biomarkers or omics. There is a bunch of biomarkers reported in the literature. The case from the neurohormonal activation that could include adrenomedulin, endothelin, renal biomarker like the cystatin, NGAL, FGF23, or biomarker more related to the fibrosis remodeling process, galectin-3, GDF15, ST2 are mentioned. The use of troponin as a marker of necrosis has been also evidence as related to the prognosis of heart failure patients. What I will zoom in through this recent data is that the etiology of heart failure has changed. There is new origin like calcific aortic valve disorders. Leading to the research to focus on biomarker of calcification, different cases, back to the FGF23, fibroblast growth factor 23, a biomarker related to bone and mineral metabolism, increase in patients with CKD and related to adverse cardiovascular events, but also increase in patients with heart failure. FGF23 has also direct effect on fibroblasts and cardiomyocytes, leading to remodeling. Multiple data and all data show that FGF23 is a strong prognosis marker in patients with heart failure with reduced ejection fraction, but also a strong risk predictor in heart failure patients with preserved ejection fraction. The inflammatory path, looking in the inflammasome through interleukins, through other biomarkers, is another option nowadays. And like in the early risk estimation of the atherosclerosis by the combination of lipids and inflammatory biomarkers could be done in heart failure patient. There is more and more treatment option with targeted immunotherapy or new treatment like the SGLT2. So inflammatory biomarkers are representing other perspective of powerful risk marker in cardiovascular medicine. Looking in the metabolomics is also a possibility. You will be able to link different pathway to a disease, and you can identify novel biomarkers that could be interesting to monitor or to develop more specific assay by doing this metabolomic perspective and omics are clearly in the scope of research of heart failure. We have additional game changers in the care of heart failure, and mostly how we can move forward for prevention. So shifting from cure to care, and using what is called the prevention window. So intervention in targeted high-risk individual, not already having heart failure, but with a high risk. It's a policy that is appearing in the guidelines in the US, in Europe, and target these stage A, stage B, at risk of heart failure or pre-heart failure, which could represent patients with diabetes, obesity, hypertension, and to screen with our tool, natriuretic peptide, for example, to identify the one which could be with a higher risk and anticipate treatment and the monitoring to prevent the hospitalization and more acute episode of heart failure. Clearly, diabetes is an example of this high-risk group, and you can read on this article published in Diabetes Care in 2022 that HF remain an underappreciated complication of diabetes. If we are able to detect this high-risk or at-risk individual, we can treat, and we have a new perspective with this miracle of the SGLT2 inhibitors, really powerful in decreasing the cardiovascular mortality in diabetes, in patients with kidney dysfunction, and in patients with heart failure. So we have a treatment that we can use upfront after estimating the risk. And if you look in this recent publication, we have a global number of more than 60 million patients with heart failure. Some of them are eligible for treatment of SGLT2, about 50 million, and you can have a reduction of a worsening HF event and cardiovascular death for 7 to 8 million of those individuals. So what a number, what an impact in terms of morbidity, mortality, and cost reduction also by using this SGLT2. So treatment is there, clinician can use it. And there is also data showing the incremental cost effectiveness according to the early initiation of treatment of SGLT2 inhibitors. Last one, the use of AI, artificial intelligence, not to replace the healthcare workforce, but to support and augment human intelligence. So how we can use this data modeling to have new decision support system. Nice example from the diagnosis of myocardial infarction, the code ACS score, which was developed and clearly improved specificity and sensitivity of the diagnosis of myocardial infarction by combining clinical data, laboratory tests like troponin, and that's a new future for the laboratory medicine and the care of cardiovascular disorders. Other emerging technologies, sensors, POCT are there and represent also superb opportunities for the management of patients with heart failure. So arriving to the end of my talk, the promotional image for Euromed Lab 2025 that will be held in Brussels, IFCC FLM event organized by the Royal Belgian Society of Laboratory Medicine. So we count on you. You will discover Brussels, be there. And I would like to thank again Mindray for your invitation, and I would like really to thank you for your attention. I hope that this lecture was educative for you. Thank you so much, and bye-bye.
Professor Damin has just presented the clinical applications of cardiac biomarkers, specifically BNP and NT-proBNP, in the diagnosis and treatment of heart failure. Now, I would like to introduce Professor Alan S. Jaffe, Professor of Medicine, Cardiology from Mayo Clinic, who will share with us how to use high-sensitivity cardiac troponin to facilitate the evaluations of patients with possible acute myocardial infarction.
It's my pleasure to join you today to talk about the clinical use of high-sensitivity troponin to facilitate the evaluation of patients with possible acute myocardial infarction. Some basic ideas first. These data come from a study done by Fred Apple, where he looked at all of the different assays, their 99th percentiles, and the number that were above the limit of detection of the assay. And what you can see is all the high sensitivity assays are different. Fred already has described to you many of the analytic characteristics of the Mindray assay, but they're going to be unique and they will need to be fit into the protocols we talk about, and specific validation studies will be necessary to define the specific values that will be important. What is important is the idea that you can't extrapolate numbers from one assay to the other. In addition, for all the high sensitivity assays, and I understand this is the case for the Mindray assay as well, that women have lower values than do men. There has been some controversy in the area of acute ischemic heart disease about how important this is, but I will tell you I'm a big advocate for sex-specific cutoffs. I think they help. These are data that were presented from the Edinburgh group looking at the outcome in women with suspected acute coronary syndromes utilizing the Abbott assay. And the upper line indicates what happens if you have a normal value clearly below any of the p-values, an abnormal value in the gray line. If you take those individuals who are between the cutoff for men, which is about 35 to 36, and the cutoff for women, which is 16 to 17, you can see they're a very high-risk group. So it's not simply using sex-specific cutoffs to make the numbers look better. These are patients who really are at risk, and many of us have argued that this effect is underestimated because women so often present, although they have chest pain, they often also have additional symptoms that make them less apt to be recognized. This is obfuscated in European trials because they take patients only with chest pain that is pretty typical, and these patients may not get in, and that may be one of the reasons why European studies are less enthusiastic about the use of sex-specific cutoffs. One of the ways to think about using high-sensitivity troponin is by deciding what the pretest probability of disease is for any given clinical presentation. If you think ischemia is highly unlikely, then even an elevated troponin shouldn't make you think that an MI is likely. You can see here, and I don't agree with the numbers, but it doesn't matter. The concept is what is important, and that is that if ischemia is unlikely, a minor elevation in troponin is only associated with a very modest, small percentage of MI. The higher the value, the more likely MI is, but even then, it's certainly less than other common presentations. The same thing for the intermediate probability. And for the high probability, sometimes if you're really sure ischemia is present, even minor increases in troponin may be adequate to move forward for treatment early on. But if indeed you don't make the pretest probability and decide what the risk of MI is up front, you end up with the troponin becoming the deciding factor, and then one ends up with debates as to what it means. If you use this framework, it will help clinicians do this in a more intelligent way. The way to think about high sensitivity troponin is shown here in this diagram from the universal definition, which I helped to develop. If you have an elevated troponin value above the 99th percentile, and I would argue using sex-specific cutoffs, and you have a rise and or fall, and we'll talk about how to operationalize that in a few minutes. If you have acute ischemia, then you have acute myocardial infarction. We could argue whether it's type 1 or type 2, and we're not going to get into that today, although be glad to entertain questions about that if there is interest. If you don't have acute ischemia, and this is a bin that is sometimes underutilized, you could have a rising and falling pattern and you have acute myocardial injury, acute heart failure due to dynamic stretch and increases in preload, myocarditis, etc. can cause critical illness, can cause increases in troponin with a rising and falling pattern. That's not myocardial infarction. That's probably myocardial injury related to the underlying stressors in any given circumstance that go to the myocardium. And if you have a troponin elevation that is stable and unchanging, with one exception I'll show you at the end, you often have structural heart disease of one sort or another. That's the association and the reason why patients who have chronic kidney disease have elevated troponins. It's not because troponin is cleared renally. There's a very small, if any, component that is cleared renally. It is because of concomitant structural heart disease. Now, this is conceptually important because if one looks at the advantages of high sensitivity troponin, it is not that it increases the frequency of identification of patients who have acute ischemic heart disease. It does that modestly and changes patients who used to be called unstable patients with unstable angina into a more secure diagnosis of non-STEMI. But it identifies high-risk patients who have other cardiovascular diseases, such as heart failure or arrhythmias, and the high-risk group of individuals who have non-primary cardiovascular diagnoses, like sepsis and acute respiratory failure, COVID, for example. And what you can see is that the higher the troponin, the worse the prognosis, regardless of the bin that you're in. So whether it's acute ischemic heart disease, other cardiovascular comorbidities, or patients who have non-primary diagnoses of cardiovascular disease but have elevated troponins, they're all at increased risk. So these are not things that should be ignored. These are our own data, just giving you some comparisons. This was before and after we used troponin T, not troponin I. But when we did that, we saw a modest increase in acute MI. You can see from 3.3 to 8.1%, mostly type 2, that is supply-demand MIs, because we know they elaborate less troponin, but a marked increase in the frequency of myocardial injury, just like in the Sweetheart trial. Now, this is a little bit less if one moves from a good cardiac troponin I assay to high sensitivity troponin I, because it's the baseline and the cutoff that is used that is important. And troponin T was uniquely insensitive, so we saw a bigger signal. With cardiac troponin I, if you were using a good assay prior and the appropriate cutoffs, this increment in difference in myocardial injury will be much less. But before you call something myocardial injury, you need to be able to explain why the myocardial injury is there. So, for example, if you have somebody who has no structural heart disease and is otherwise pristine, hard to say without a cardiovascular diagnosis what the etiology is. And those patients deserve additional scrutiny. And we'll use an example later to emphasize this point. Now, I'm going to use the European Society of Cardiology 1-hour algorithm as a template to describe some of the issues that are involved with using high sensitivity troponin. It's not because we endorse it. We, in point of fact, do not use the 1-hour algorithm. We use a 2-hour algorithm. I'll show you why. But it does allow us to bin out some of the important characteristics for clinicians to think about. One of those characteristics is shown here in this left panel, and that is if one has a very, very low value of troponin at the time one presents, the likelihood that eventually they will develop the metrics that make for the diagnosis of MI is small. This has been shown for cardiac troponin T, shown here in a meta-analysis which several of us published. In patients with non-ischemic ECGs, you can see that the sensitivity of using this measure to exclude MI is very high, 99%. And it's important. A lot of people use negative predictive value, which is dependent on the prevalence of disease in the population. That can be confusing if there's a low prevalence of disease. So sensitivity is a better measure. But one can also see this with all the cardiac troponin I assays. This is what I call a Mills plot. And it basically looks at values for a given assay. This turns out to be the Beckman high sensitivity assay, all the way down, and asks, what is the sensitivity as you go down and down? And as you might imagine, the higher you can, higher value you can use, the greater percentage of your population that might be included. So it's important to go as high as you can while recognizing that at least ED physicians would like to know that the miss rate is 1% or less. That is to say, they are the ones who would feel strongly about 99% sensitivity. Now, one reason this works is not only because of the elaboration of troponin from a given event, but because one doesn't often have a very low cardiac troponin if one has cardiovascular risk factors, as shown here. The one exception in this study was smoking. And I don't understand that. No one else does either. So in addition to saying that you don't have an acute event, a very low value suggests that you don't have the underlying risk factors for atherosclerotic disease, and that likely augments the sensitivity of this approach. It's important to understand, however, that if patients come in very early before they have a chance for troponin to be elaborated, you can miss them. And that's shown here in these data from the group in Edinburgh, suggesting that for patients who come in less than 2 hours, that the sensitivity, they use negative predictive value here, goes down. You can compensate for that, as shown in this slide, by using still lower values. So as I talked about optimizing the percentage of the population, which means you want a higher value, if indeed you want to evaluate patients between 0 and 3 hours from the onset of symptoms, you need to go still lower to meet the requisite 99th percentile. Some caveats. These are data from the Israeli group. They point out that if you evaluate older individuals with lots of comorbidities, that this strategy works less well, and therefore, not surprisingly, if indeed you take patients who have known coronary artery disease, the strategy works less well. So this is not something you can simply put on autopilot and just use. There needs to be a clinical component of this involved to make sure that you do not miss patients. A second part of the ESC algorithm, which I now will criticize, suggests that between 0 time and 1 hour, a change of 3 rules out disease and a change of 5 rules in disease. And I'm going to put on my laboratory medicine hat for this. This is our protocol, our precision protocol for the precision of high sensitivity troponin T, because that's what we use. And what you can see is that the imprecision is too high for us to be able to distinguish between 3 and 5. Pete Kavsek and at Toronto and I did a study just to look at this more clearly, where we took samples and put them on the bench for 3.5 hours and measured them 3 times. And when you did that, in particularly for low values, about a third of the patients shifted diagnostic category from ruling out to ruling in. So the reality is that these very tight windows and different small deltas are apt to miss some patients. It's probably true that there are not a huge number, if indeed you're dealing with classic chest pain patients, but in a more comprehensive group, which is what we evaluate often in the United States, this could be a problem. There are some clinical data that suggests that this may be important as well. This comes from this trial called RAPID, and it's a complicated trial, and we could answer questions about this subsequently if you are interested. But in essence, when they looked at a blinded use of the 0-1 hour protocol, they found 13% of patients came back during a 30-day follow-up, and it was a long-term hazard. It's not clear if this is related to the single sample rule out that was being used, and perhaps not as conscientiously as I have emphasized, or is this due to the small delta changes? For that reason, we at the Mayo Clinic have used the 2-hour algorithm. This is for troponin T. You can see the ruling in and ruling out metrics. We use a value less than 4 to rule out at 2 hours, a value greater than 10 to rule in. You can see nothing is perfect. There is some overlap, but it works fairly well. So this is our 2-hour algorithm that we use modified. We have validated the use of a low value of troponin T, and we do use the single sample rule out. I should point out to the clinicians here, it's very important that although this rules out an acute event, the higher your troponin, the greater your long-term risk, as shown in this slide. What you can see for cardiac troponin I on the left and troponin T on the right, that the higher your value, even within the normal range, the greater your long-term risk. So it's terribly important to make sure we distinguish between short-term risk in evaluation of MI and long-term risk. Now, another part of the protocol that is valuable in the European protocol is the use of a high value to include MI, because it has high positive predictive value. And if one looks at the validation done of this, and the ESC algorithm suggests a value of 52, we have suggested for the United States a value of 100. They would say the positive predictive value is nearly 90% for the classic patient who comes in with chest pain. However, in the United States, we have many, many older people, and older individuals have high baseline values for cardiac troponin. We have lots of dialysis patients, and if you used 52, you'd be admitting half of our dialysis patients. And critically ill patients often have elevated troponin, so you'd be evaluating and including 50% of those. That's why we picked 100 or a rule out of 10 to rule in recognizing that that's not all MI. Some of this is ruling in for myocardial injury, and then one needs the clinical piece to tell you whether or not you have acute MI. And I would emphasize, I'm not showing you these data because they're in review now and still boycotted, but when we evaluate this strategy in all comers, because we evaluate patients with subtle presentations as well as those with more overt presentations, the positive predictive value is less than 50%. However, if you apply this to a classic chest pain cohort, it's about 77%. So it is of some value, but it is far from perfect. Some cautions. This was a patient I saw when I became aware that we were missing these patients. And I went down to the emergency room, and this is the first patient I saw. The gentleman who had a history of a freezing sense in his sinuses, so the ED thought that wasn't a very good story. But it went to his chest very rapidly. It was exertional. He had some pain at rest. He thought his asthma was getting worse. He'd been stressed. He was adopted. His ECG is shown here, not very impressive. His troponins, however, were elevated, but they weren't changing. When I looked at this gentleman, I said, there's no other reason, getting back to what I told you initially, for this gentleman to have an elevated troponin. He didn't have known structural heart disease. My physical exam did not suggest that was present, although subsequently an echocardiogram confirmed that, and that's always reasonable if one is unsure. And so I said, I wonder if this is ischemic heart disease, and in point of fact, it was. Now, why does this occur? Well, it's not as uncommon as you would think. This is a study from the Sweetheart trial that suggested that 26% of patients who have heart attack, non-STEMI, will not have a changing pattern. And the reason for that is shown here in this diagram from the universal definition. The upslope of the time concentration curve is quite brisk, so you see a change and a rise. But the downslope is relatively slower. So if indeed one presents later after the onset, and later depends on the substrate because the release of troponin depends on blood flow. So with an open artery, this may be 8 or 12 hours. With a closed artery like a STEMI, it may be 16 to 18 to 24. But once you're on the downslope, it may be harder to see a changing pattern. So if indeed you have a patient like the one I showed you, who doesn't have a changing pattern and has no other explanation, at least consider whether or not ischemic heart disease is present. There's another case. It was a gentleman who had a positive family history. He had a positive calcium scan in the past. He had pretty classic chest pain. He came to the emergency room. Here's his electrocardiogram for those of you who are clinicians. Not terribly impressive. His troponin T values were not different. And my colleague who was working in the ED said, but I'm really suspicious this guy has something. But the troponin isn't showing it to me. Why not? And I said, and I would reiterate this, if indeed you're suspicious, you should do more. Nothing is 100%. And he put this gentleman on a treadmill, and you don't need to be an expert to see the marked inferior ST elevation and subsequent cath lab documentation of a high-grade right coronary artery. So I don't quite understand why unstable angina is still present. But no matter how good your assay, including the Mindray assay, there will be patients who have unstable angina. So again, this is not a technique you can put on autopilot. A third case, and then we'll end. This was a 78-year-old woman who had hypertension. She'd been evaluated by one of my colleagues because she was having more chest pain. She came in, excuse me. She had had a stress test previously, so the ED ruled out pulmonary embolism, and when they didn't find it, they admitted her to ischemic heart disease service. Wasn't clear. Here's her electrocardiogram, not very informative. Her troponins were on the margin. 10 is the sex-specific cutoff for troponin T. It then subsequently rose, but the time that I saw her, actually just before I saw her, we didn't have that value, but she was sent by the house doctors for an echocardiogram, and they called up and said she's got a septal abnormality. Now, I'm not going to play this to show it to you. You can see the septal abnormality here. So it sent her to the cath lab, and she had normal coronary arteries. But an MRI suggested a perfusion defect in her septum. So what is this? This is so-called MINOCA, myocardial infarction with non-obstructed coronary arteries. This is something that we are seeing more and more with high-sensitivity troponin probes. It's a terribly important entity. If one looks, one can't get an MRI in everybody, but if you have suspicion, doing an MRI sooner rather than later is important. The yield is much better if you do it sooner. And what you can see at the bottom in this analysis that we published some years ago, the most common reason for the elevated troponin in this subset of patients is myocarditis. But there are some small infarctions as well, 22% of patients, some stress cardiomyopathy, etc. The earlier you do this, the better the yield. Now, this is a complicated circumstance, and I point to this from an analysis done by a woman named Harmony Reynolds at NYU, where she looked at 42 women who came in with exactly this presentation, and it's much more common in women. And what she found was, despite angiographically normal coronary disease, when one did IVUS in this instance, you can do this with OCT as well, plaque rupture was present in about half of the patients. So these actually are plaque rupture events below the ability of the angiogram to detect, in addition to things like SCAD, microvascular disease, and the like. And if you look, the prognosis of these individuals is not as bad as those who have obstructive coronary disease, but it's not normal either. And so it is worth identifying these patients and starting to treat them, in particularly most often with things that are important for the treatment of ischemic heart disease. What I've tried to do is give you a feel for how high sensitivity troponin, and you'll have to define the specific cut values for the Mindray assay if you decide to use that assay that applies to this. For the other assays, a variety of studies are available in the literature that will define those cut points, and they're elaborated in the European Society of Cardiology guidelines. One could quibble some with those, but they're pretty accurate. They're better in the 2018 guidelines than in the more recent ones. The important thing, I think, is that no test is perfect. And so it's not the data, but how you interpret it that turns out to be important. And with that, I'll stop. And if there are questions, I'd be glad to entertain them. Thank you very much.
By now, you should have gained an understanding of the crucial significance of the cardiac biomarkers, especially cardiac troponin, in the management of acute myocardial infarction. It is evident that they play an invaluable role in identifying high-risk individuals and enhancing the treatment of patients with cardiovascular diseases. So far, Mindray has established 3 R&D centers across the globe specifically focused on in vitro diagnostics. Among these R&D centers, I would like to specifically introduce HyTest, a prominent industry leader in raw materials for in vitro diagnostics that Mindray acquired in 2021. Since its establishment in 1994, HyTest has been dedicated to the development and manufacturing of antibodies for cardiac markers. Through its commitment to delivering high-quality immunological reagents for cardiac studies, HyTest has emerged as the leading suppliers of choice for cardiac markers. Building upon the expertise of HyTest, we have successfully developed new cardiac assays, namely high-sensitivity cardiac troponin I and NT-proBNP, contributing to the expansion of our comprehensive menu of cardiac tests in the field of immunoassay. Now, let me introduce Dr. Zhang Yi, who will delve into the advanced technology incorporated into our latest cardiac products.
Thank you, Miki. Dear guests, thank you for being here with us today. My name is Zhang Yi, and I am in charge of the research and development of cardiac markers at Mindray. The heart is believed to be a sacred and mysterious organ for a long time. In the 16th century, Leonardo da Vinci created the first ever illustration of coronary arteries in human history, inspiring the research into cardiovascular physiology and pathology for the following 5 centuries. The history of cardiovascular disease research is a long tale of pervasive accumulation and breakthroughs. Today, we will share with you the inspiring story of Mindray in the research of cardiac biomarkers, particularly high-sensitivity cardiac troponin. My topic today is high-sensitivity cardiac troponin, a key chapter of Mindray's quest for enhanced cardiac diagnostics. In 1929, Werner Forsman, a 25-year-old intern fresh out of medical school, made a bold move in the hospital's operating room. He punctured his left cubital vein and inserted a rubber tube connecting it from his arm vein to the right atrium. He proceeded to record his procedure using X-ray photographs. This groundbreaking achievement made him the first physician to insert a catheter directly into a human's heart, pioneering the field of cardiac catheterization. As a result, he was awarded the Nobel Prize in Physiology or Medicine in 1956. Cardiac catheterization is one of the most fundamental techniques in the diagnosis and treatment of cardiovascular disease. It has paved the way for the rapid development of various interventional procedures such as coronary angiography, PCI, and stent placement, leading to a drastic reduction in mortality rates associated with myocardial infarction. Since the 1990s, interventional procedures for myocardial infarction have become as routine as appendectomies, enabling effective treatment of myocardial infarction. However, why do people still fear at the mention of myocardial infarction so much? This is because myocardial infarction has a rapid onset and is often associated with critical circumstances. Without timely diagnosis and prompt treatment, there can be excessive deaths of cardiac cells. Unfortunately, these cells cannot regenerate, making it likely for the patient to face a poor prognosis. The prompt and accurate diagnosis of myocardial infarction is just as important as its treatment. In 1903, the Dutch scientist William Einthoven invented the first electrocardiogram machine in the world, which led to the use of ECGs for diagnosing heart attacks by 1930s. While the diagnosis became possible, the rate of diagnosing myocardial infarction was actually less than 33% during the presence of non-ST segment elevation myocardial infarction, which is non-STEMI. The presence of non-STEMI promoted a transient towards the use of biomarkers. The evolution of biomarkers, starting from the cardiac enzymes in the 1960s to CKMB in the 1970s, increased the diagnostic rate of myocardial infarction to 50%. The fundamental issue with these biomarkers is their limited specificity, as they could interfere with clinical assessment in cases of non-myocardial injury. The ideal biomarker emerged in 1987 with the introduction of cardiac troponin. It is expressed in cardiac cells with 100 specificity and can be rapidly released from those cells within 30 seconds, making it highly sensitive and specific. While the biomarker itself was perfect, the early assays were not as optimal. They had a sensitivity of only 10 nanogram per ml and took nearly 30 hours for detection. In response, efforts were made to improve the cardiac troponin assays through the use of conventional cardiac troponin. The diagnostic rate for myocardial infarction could reach up to 70%. Cardiac troponin gradually gained recognition in various guidelines and protocols. In 2020, the European Society of Cardiology announced that the world was about to enter an area of high-sensitivity cardiac troponin. The increased sensitivity of high-sensitivity cardiac troponin results in a 50% enhancement in detecting non-STEMI, leading to a decrease in patient mortality from 70% to 6%. Moreover, it lowers the diagnostic thresholds for unstable angina and improves the accuracy of diagnosing myocardial infarction. The use of high-sensitivity cardiac troponin increases the diagnostic rate for myocardial infarction to over 80%. High-sensitivity cardiac troponin is provided as a Class 1 recommendation in various guidelines, making it very core biomarker for assessing myocardial injury. Utilizing high-sensitivity cardiac troponin also poses challenges. What should the target for sensitivity, and what should the target for specificity, especially for the anti-interference capacity? According to the globally accepted definition of high-sensitivity cardiac troponin, it should be capable of detecting cardiac troponin in over 50% of healthy individuals for both genders, while maintaining a total impression CV below the 10% at sex-specific 99th percentile of the upper reference limit. This definition sets a minimum threshold rather than an optimal one. In 2009, Professor Fred Apple, the globally renowned expert in cardiovascular biomarkers and chief scientific advisor at HyTest, established the thresholds for high sensitivity as a 50% detectable rate in apparently healthy individuals. The highest level of performance should aim for a 95% detectable healthy individuals, which has not yet been achieved in the industry. Improved sensitivity enables easier detection for transient myocardial injury and offers a safer approach to ruling out myocardial infarction with a single measurement. Improved sensitivity is the one target pursued by the entire industry. The performance of cardiac troponin has been improved a lot in the industry. It is the development of antibody that supports the ongoing improvement in the sensitivity of cardiac troponin. Antibodies are the heart of immunoassay, undoubtedly. The use of these antibodies follows a rather regular pattern. Why? First, there is a limited number of antigen epitopes available for antibody recognition. Second, the availability of high-quality antibodies is also limited. The detection of cardiac troponin evolves as our knowledge advances. The presence of phosphorylated sites and enzymatic cleavage sites on the surface of cardiac troponin can impact its detection. Additionally, the presence of endogenous and autoantibodies on the surface of cardiac troponin can influence the accuracy of detection. Therefore, the regions available for detection on the cardiac troponin are limited, as is the availability of effective antibodies. From where does this knowledge originate? It is from HyTest. In 1994, HyTest introduced the world's first high-quality anti-cardiac troponin antibody, followed by the industry's first international reference material for cardiac troponin. Subsequently, they continued to innovate by addressing the influencing factors we just discussed regarding the surface of cardiac troponin. HyTest's scientific research and high-quality antibodies are driving industry development. In 2021, Mindray acquired HyTest, which gave us access to profound knowledge, including the academic papers and also even the records in the notebooks. HyTest's recent research on cardiac troponin has offered valuable insights, particularly over the past 5 years. Their studies have focused on the release process of cardiac troponin during myocardial infarction, the identification of new cleavage sites on the cardiac troponin, and a better understanding of those regions that easily influenced by the interference from autoantibodies. This enables us to select the most appropriate combination of antibodies based on principles. By leveraging this newfound knowledge, we can achieve world-class sensitivity right from the outset. Even with this level of sensitivity, our detectable ratio for healthy individuals is limited to 65%, which is classified at level 2 and aligned with the current industry standard. There is still a significant gap from achieving the ratio of 95%. Furthermore, we need to design and engineer antibodies, which is relatively almost untapped area in the IVD industry. Even within the well-established antibody therapeutics industry, antibody engineering is still not an easy task. Antibody engineering demands a proven track record in antibody production, particularly with regard to cardiac troponin. It requires an in-depth understanding of the antibodies themselves, including the antibody to make appropriate adjustments in theory. Additionally, well-defined design requirements and a specific direction for adjustments are essential in this process. In such a context, Mindray and HyTest have come together to form a perfect combination. Since the 1970s, at the dawn of monoclonal antibody technology, the pioneers, the startup scientists of HyTest, embarked on laboratory-based efforts in antibody design and engineering, which was more than 1 decade before the HyTest were even founded. After nearly 40 years of gathering knowledge and experience, we have established the most extensive platform in the industry for antibody design, research, and engineering. From designing the immunogens to implementing the immune process and adjusting the expression system, These accumulations are a result of numerous experimental iterations, valuable lessons learned from failures, and the unparalleled expertise and practical experience that surpasses conventional textbooks. The depth and breadth of our accumulations are unmatched. As I remember, it was during one of our monthly meetings with HyTest scientists towards the end of 2021 that we proposed this concept. What struck me was the immediate resonance that unfolded between us. Mindray has bring forth clinical demands that originate from real-life situations and drive the requirements for product development. We collaborated from different dimensions on modifying the antibodies within the LP system and improving their affinity. We went on to perform directed evolution on cardiac troponin antibodies, which led to over 100 times increase in terms of affinity and a 50% reduction in LOD. With our immense advantages in antibodies, we have developed high-sensitivity cardiac troponin products with sensitivity levels that are infinitely close to level 4. We achieve an impressive detection rate of 93% among healthy individuals. In spite of utilizing these same samples, our detectable capabilities significantly suppress the current industry leading level. We deliver the highest level of sensitivity across the industry. So, does the highest level of sensitivity good enough? Specificity issues, particularly interference issues, remain prominent in cardiac troponin assays. Inaccurate results can lead to overtreatment and trigger serious complaints. Over the past 3 decades, advancements in the immunoassays industry have equipped us with an adequate understanding of interference and universal solutions to address this. The prevailing consensus is that interference is unavoidable due to the widespread presence of interfering substances, such as heterophile antibodies. The binding of capture antibody and the detection antibodies can lead to false results. By implementing all available universal solutions, our prototype product managed to achieve the common level of anti-interference ability in the industry, with the probability ranging from 0.3% to 0.5%. This means that a hospital dealing with about 100 samples every day may encounter 2 to 3 cases of interference per week. This is not an exaggeration. It's just that the interference level is low, only several tens of nanogram per liter, and not that easily detectable. We were wondering whether the 0.5% interference was solely caused by heterophile antibodies. During our development process, we came across an abnormal phenomenon where certain samples remain unblocked by universal heterophile antibody blocking regions, while a significant decrease were made after PEG precipitation. So could this indicate the presence of large proteins or the large complexes in the system? Does this imply that there are some exceptional patterns in the interferences we have detected? What is the proportion of these exceptions? They account for as much as 80%. So it is crucial to identify and address these patterns of interference. We had to start searching for a needle in a haystack. Our task was to identify this specific pattern of interference within the population and find a way to address it. First, we need to establish a representative sample pool or a universal sample bank. We collected samples from various regions across China, encompassing different risk factors, geographical locations, ages, and genders. We built an interference sample bank that represents high-risk samples from a population ranging from 1 to 2 million individuals, making it the most comprehensive of its kind in the industry. Then, we assumed the role of detectives, piecing together and reproducing the scene of interference. We discovered that the interference was occurring within the designated antibodies, specifically in the fixed sites. The interfering substances consist of the core components of immunoglobulins and other proteins. Building upon this fundamental framework, we partnered with the leading research institution in China. It's from the Chinese Academy of Sciences, to employ high-resolution proteomics approaches to identify several high-risk substances associated with these new patterns of interference. Based on the results, we devised a new, highly efficient blocking approach that differs significantly from the conventional approaches. It enables targeted blocking of the essential components within the interfering substances, effectively addressing this particular type of interference. So finally, we achieved a reduction in interference probability from 0.5% to 0.015% in interference sample bank across 6 real-world evaluation sites. We managed to achieve an interference probability below 0.01%. By implementing our innovative universal and specific anti-interference blocking mode, we have reduced the interference probability from 2 to 3 cases per week to 2 to 3 cases per year, marking a new milestone in the industry. Internally, we monitored the entire analytical system for a long period of time. Factors such as instruments, reagent batches, calibrations, and testing persons, they interact with each other to ensure we could achieve the constant stability. With such a reliable design, we confidently submit our product to authoritative institutions for rigorous performance evaluations. The product was evaluated at a top cardiovascular biomarker research laboratory in the US, FresLab, where it received an excellent rating from both the professors and the technicians. In the meantime, Mindray's high-sensitivity cardiac troponin I product underwent a comprehensive and systematic performance evaluation at Wuhan Asia Heart Hospital, one of the top 10 specialized cardiac hospitals in China. The product demonstrated excellent precision, sensitivity, and specificity. Its diagnostic efficacy was outstanding, along with extremely high level of accuracy and safety. Apart from exceptional products, it is equally important to have an advanced diagnostic and treatment process. Over the past 5 years, the industry have been actively exploring more rapid diagnostic solutions. Together with Professor Fred Apple, we conducted 0 to 2 hour diagnostic algorithm research and established the industry's most advanced diagnostic process. In China, our collaboration with the National Cardiovascular Center, Beijing Fuai Hospital, led us to conduct relevant research and developed a rapid diagnostic process specifically tailored for Chinese population. The research findings will be published this year. These research efforts will enable us to effectively optimize Mindray's high-sensitivity cardiac troponin for high-sensitivity applications and elevate its performance to an international leading level. The acquisition of HyTest demonstrated Mindray's complete capability in the research and development of diagnostic raw materials. Now, the launch of high-sensitivity troponin I takes us even further, establishing Mindray as a forerunner in the field of chemiluminescence detection. This accomplishment marks a momentous milestone for us. By leveraging the combined strengths of HyTest and Mindray, we persist in conducting fundamental research and integrating targeted modifications of raw materials with advanced engineering. This has led to the development of world-leading cardiac biomarkers, and we are trying to make the high-sensitivity cardiac troponin to be a more perfect assay. Moving forward, we will continue to push the boundaries and address the challenges and concerns surrounding the diagnosis, treatment, and prognosis of cardiovascular disease. By harnessing Mindray's interdisciplinary strengths, we aim to establishing a comprehensive and innovative solutions dedicated to cardiovascular health and to better meet the evolving needs of our customers. Together, let us embark on a new journey that starts from the heart, united in our mission to safeguard cardiac health. Thank you for your listening. Now let me give the floor to the host.
Thank you, Dr. Zhang Yi. In our dedication to providing high-quality cardiac assays, Mindray has collaborated with Professor Fred Apple, the chair of the IFCC Committee on Clinical Applications of Cardiac Biomarkers, in the development of these revolutionary products. Today, we are privileged to have Professor Apple join us to share the captivating journey of our partnership.
It is my honor and privilege to be part of Mindray's online launch of their fantastic high-sensitivity cardiac troponin I assay. At my presentation today, you can see my title is High-Sensitivity Cardiac Troponin Monitoring, Today and Future Applications for both rapid diagnostics and risk assessment for myocardial infarction and myocardial injury. As I show you here, is my disclosures. So I start with the definition of both acute myocardial infarction and the criteria for acute myocardial injury defined by the fourth universal definition of myocardial infarction. And in 2018, the Global Task Force for the first time defined myocardial injury as a patient who has an increased cardiac troponin I or T with at least one value greater than the 99th sex-specific upper reference limit. Now, myocardial injury, of that, acute myocardial infarction is one form of myocardial injury, and this involves acute injury with clinical evidence. Troponin is not a standalone test. With clinical evidence, with symptoms, EKG, and imaging, which in patients who present with myocardial ischemia, with at least a rising and falling troponin pattern with one cardiac troponin value greater than the 99th percentile using high-sensitivity troponin at an upper reference limit. What's really impressive with the cardiac troponin becoming a high sensitivity assay is you'll see data I present for the Mindray assay. The improved analytics is key to its use. With the low-end ability to measure troponins within the reference interval down to the limit of detection, we are now able to monitor our patients using quality control material within the reference interval. And what defines a high sensitivity assay is the ability to measure greater than 50% of normal individuals with a measurable value greater than the limit of detection, and to have an imprecision of less than or equal to 10% of both the male and female sex-specific cutoff. Now, this will help clinicians tremendously with their cardiology consults and their clinical referrals. As I'll show you using examples of another assay as we're developing clinical data for the Mindray high sensitivity troponin I assay, it'll allow for early triage, early rule out of patients from emergency rooms. It'll allow the ability to send patients home with very low risk at 30 days, a marker that emergency medicine physicians and cardiologists use. We'll address using both a baseline sample and a serial, either 0-1 or 0-2 hour samples for early rule out. And we'll use the 99th percentile as the diagnostic tool to decide if someone has had a myocardial injury, but more importantly, a myocardial infarction. And we'll also get a suggestion of a high predictive value of myocardial injury that someone may need to be admitted with a high positive predictive value based on troponin. And we'll also see some data that will assess the risk of a continuum from any measurable value to increased values. So I show, and this will show up in the data I show you with the Mindray assay, is the assay imprecision is key. In these two patients I show in the upper panel, the red rising and falling serial patterns of these two patients shows that there is much noise that would indicate it looks like it's a rising pattern or falling pattern. But when the same samples are measured on a high sensitivity assay in green, you can see they're not a rising in pattern. So as we can see in the cartoon, moving from a contemporary troponin assay, which had an imprecision of 20% at the 99th percentile, we now can move to the high sensitivity assay with much less noise, with a less than 10% CV, not only at the 99th percentile, but even with the Mindray assay, as we approach the limit of detection, imprecisions down to 10%. Another schematic that I'll show and discuss today is the ability for early rule out, as I mentioned, the ability to measure down to the limit of detection, LOD, measure down to the limit of quantitation, which is the 20% CV value. And in the United States, unfortunately, the FDA only allows the ability to report results down to the limit of quantitation, the 20% CV. But as I'll show you, being able to measure down to the LOD allows a greater percentage of patients to potentially to be triaged early from the emergency room to be discharged at home. And the lower part of this cartoon, this was a review paper published in Circulation. You can see my recommendation is laboratories use the sex-specific individual cutoffs for both women or females and males. And you'll see there's a significant difference between the two. Now, when I look at all the regulatory assays, regulatory approved assays for cardiac troponin, you can see here that since 2007 to 2021, that many assays have been approved by many European and China FDA and the US FDA that have approved the assays to be utilized. To the best of my knowledge, you can see here currently in China, the ET healthcare assay is used both for troponin I and troponin T. But when we look at the high sensitivity assay, one of the very positive things, it's just not only used now for the diagnosis as we see in this middle circle. As we mentioned in the green, we can look at low risk, and it's predicated on having a value that allows us to have a 99.5% negative predicted value to safely to be able to triage patients home in those that have just a symptoms suggestive of ischemia. I've talked about high risk with a high positive predictive value of greater than 70%. And then in the purple box, I'll mention that the importance that Mindray will develop a continuum of risk. So you can see here, there's really 4 different ways this high sensitivity cardiac troponin will be used in clinical practice. So this is a busy slide, but what I'm showing here is a paper in the middle that was based on the American Association for Clinical Chemistry Universal Sample Bank, in which my lab took all the manufacturers' assays that we could gather that had regulatory approval, and we used the Universal Sample Bank to measure both men and female 99th percentiles. And you can see the bars in these graphs represent the actual ability to what the 99th percentile were, and the circles represent the measurable ability to measure at least 50% of individuals of the normal population. And I overlay the Mindray assay data that has been published now in abstract form, and there's a paper we're drafting now. You can see using the Universal Sample Bank, we presented this data at the Anaheim, California AACC meeting at a poster, shows that greater than 90% are measurable for men and women. And the difference between men and women, the male 99th percentile was 14 nanograms per liter using this sample bank, and 5 nanograms per liter for females. You have to keep in mind, based on each individual cohort of normals, you will see potentially different cutoffs. So based on your own populations and distributions of males and females, age, gender, ethnicity, race, we will see different cutoffs. You can see as on the right here, I show in the blue, this was a point of care assay that we also recently published. You just get a feel the differences in numbers. Doesn't mean one assay is better than the other. You just have to know your assay. In this slide, I'm showing you that when you approach a patient, you never know where you are on the presentation of when the actual index event occurred. The red line shows an acute myocardial infarction involving, but we'll never really know if the presentation is at 1 hour, at 20 hours. Someone might say the presentation was just recently, but maybe it could have been earlier. So troponin will be used to look at acute changes, which show a rising and falling pattern, or pick up a chronic injury, which typically is a flat pattern. And this is all based on the 99th percentile. And I put it into a different perspective here, looking at the different algorithms that'll be able to be used with the Mindray assay. We'll be able to look at the very early presenters, and typically it's about 2 hours before we start to see a delta. We'll be able to look at the rising pattern, but there potentially may always be not the ability to see a delta, because a patient may present when you're at the summit of that peak. So a delta may be absent if you're at that point of inflection of the kinetics of the curve. So let me show you an example which we plan to do, not hope, which we're going to do with a clinical study we're almost completing in my laboratory. This is from a paper in Circulation. And what we do is we enroll all the patients. We define who've had a type 1 and type 2 myocardial infarction. And then we start at the lowest concentration. In this assay, it was less than 2 nanograms per liter. And we identify the concentration that'll optimize the negative predictive value above 99.5% and the sensitivity at around 99%. You can see here for this one point of care assay, the circle shows you that it was safe to send home 41.8% of patients with a very high probability of not having any bad outcomes. You can see here the cumulative event rates in this group, only one outcome at 30 days that was missed. And this is another way to show, this is two different cohorts. The Siege cohort is from my lab in Minnesota, US. The SAMI cohort is from Brisbane, Australia. You can see here there were some false negatives that were missed at presentation. These are all based on baseline samples. And the samples that we missed were typically type 2 MI. So these high sensitivity assays, and we hope to show this, and I'm sure we will show it for the Mindray assay, are very powerful early rule out tools with great safety. And I put it into, if you look at the circulation paper, there's a nice schematic that shows you in this assay that we used, the low risk patients were defined as less than 5 nanograms per liter. This had about 50% patients who were allowed to be sent home. The high risk was a very high number, greater than 120. And then you have the intermediate risk that had concentrations from 5 to 119. And these are the samples that we'd want to get a second serial sample on, which will allow to decide if there's an acute injury. And you can see in this one study, we went from about 50% based on a single baseline sample. When we added a second sample, about 60% of patients on a 0 or 1 or 2 hour sample could be discharged back to their home. And the other thing I mentioned is the power of looking at, even within the reference interval, patients who present to a hospital never show an increased cardiac troponin, but yet even within the reference interval, you can see there's a 3 to 4-fold higher risk as the troponin is measured at presentation. So you can't really think of these troponins as being, it's negative for an MI and normal within a reference interval, but the outcomes are significantly different, almost similar to high sensitivity CRP in its risk potential. So when we think of troponin and the release during one's lifetime, what we have seen as overaging, that troponin levels increase and are released from the heart from many mechanisms. It could be apoptosis, it could be to myocardial injury, could be chronic disease. And we have not gotten to the point to define 99th percentiles yet based on age. So we usually define a broad age group across different sexes to look at the 99th percentiles. I took this cartoon from the HyTest group, Alice Kotruka and his group, part of Mindray. And you can see here, it's a very busy slide, but it shows us that when the cardiac troponin I, T, and C complex is released from the heart after injury, whether it's myocardial infarction or another cause, many things happen to this complex. There's the ternary complex is degraded to an IC complex. There's free I. There's complex changes with phosphorylation. And the key here is the HyTest group has successfully raised antibodies to measure the full complex of ICT, a low molecular weight form. So it opens the door for Mindray to explore, to look at fragments, which we'll talk about, and possibly try to time the infarct and get a kinetic pattern that may add great value to when the infarction occurred, or maybe even define myocardial injury, and maybe even define and differentiate type 1 from type 2 myocardial infarction. And here's another schematic, which is similar concept. Here is an acute myocardial infarction. This is done by electrophoresis, work by Jennifer Van Eyck. Similar concept by immunoassay, but this is electrophoresis. The concentration of troponin I in both the presentation sample and the degradation sample after 12 hours is exactly the same, but you can see the multiple forms that circulate over time after injury. This is where immunoassays would be a very powerful tool to differentiate the acute from the chronic injury. So let me just present some data we have published in poster form and writing up the publication. The Mindray assay measured on the Mindray chemiluminescent immunoassay analyzer, very sensitive assay. The limit of the blank was less than 0.1 nanograms per liter. The limit of detection was 0.1 nanograms per liter. When we looked at percent CV within lab and between reproducibility, the imprecision anywhere from 1 to 106 nanograms per liter ranged from 1.15% to 5%, a very precise assay. And we also show that when we actually took samples close to the 99th percentiles, the imprecision was very, very positive, less than 3%. And the schematic shows how nice this imprecision looked. It was highly linear to 30,000 nanograms per liter. We saw no carryover between a very low and very high sample, and all the analytical parameters met the CLSI limits for acceptable analytical performance. So my conclusions just on the analytical portion was excellent demonstration of precision, lower limit of detection, linearity, aligned with all the manufacturer's claims, and met our IFCC Committee on Clinical Application of Biomarker guidelines. I think it's now acceptable for clinical application. I'll show you that we looked at interference, and it had really no interference that we could identify. We observed sex-specific cutoffs between males and females with good imprecision. Our numbers were slightly different than the manufacturers, but I would expect it to be based on different populations. So now it's time for clinical studies to start. And here's a generic slide published in JACC in 2019. So when you're validating a high sensitivity assay, you want to look at multiple interferences. And this shows here, what we did in our laboratory, we showed that we saw no interferences in our studies, whether it was skeletal troponin I, skeletal troponin T, cardiac T, troponin C, actin, actinomycin, myosin light chain, myoglobin CK&B, or biotin. So less than 15% interference, which is not a problem with the assay. So I just think this is a very excellent assay analytically. Now, the one thing we are in the process of doing right now is we have a registered clinicaltrials.gov study. It's called MERIT-TNI. It's a Mindray high sensitivity cardiac troponin I assay, the analytical and clinical evaluation for the diagnosis and risk assessment of myocardial infarction. And a brief study is the primary goal is to look at the diagnostic ability and the quantitative determination in our population, looking at a 0 and 2 hour sampling set. We're going to look and examine it as an aid for the diagnosis for ruling in and for ruling out AMI using the CL-1200I instrument. We're going to be looking at risk assessment, and we're going to look at that 30-day safety outcome in patients that come to our ER, maybe discharged early. It's all compared to the Abbott Alinity assay. But what the thing is, we're going to hopefully show very similar but unique data to the Mindray assay. And our status at present, our goal is to enroll 1,500 consecutive patients that met a very rigid criteria. And as of this last week, we have enrolled 1,100 subjects into our study. So the future potentially, and Mindray and I have talked about this, is at least in the United States, there's a lot of pressure on manufacturers to potentially look at point of care assays, because the goal is to be able to have a turnaround time from the time a patient walks in the door to the time a sample arrives in the lab within 60 minutes. The analyzer is a very rapid analyzer. And I think the future to complement the central lab would be to develop a point of care assay to allow non-laboratory professionals like nurses to do real-time testing near the bedside. And this will improve patient triage in very busy emergency rooms, reduce length of stays, and also hopefully reduce cost of someone who may have to be admitted to a step-down unit to wonder if they're not, and wait longer times to see if they've had injury or myocardial infarction. And I think both with the central lab and with the point of care potentially in the future, these will complement each other, but it's going to be very exciting just to have the central laboratory assay implemented by Mindray in their introduction to this assay. So some take-home points of in laboratory medicine regarding high-sensitivity troponin. One of the most important things when you roll out a new assay is communication. It has to have a team approach from the laboratory, medicine department to emergency medicine and cardiology. It's important to do, even though people may publish, we may publish, is to do a small, unique validation on rule out and diagnostic decision making. It's important to be able to use this assay to assist and distinguish between acute and chronic injury, because we want to make sure we can detect this early. It provides great opportunities with this new assay to allow clinicians to make early decisions. And as I showed you, the analytics are excellent for this assay. So precision, low-level detection, and an expert opinion is when you change lots to lot in an assay, like everybody does in different instruments, it's kind of a consensus that when we have low concentrations measured, lot to lot variability should be in the range of 2 nanograms per liter to make sure we're comfortable with changes between lots. This is a global community presentation. Everyone needs to be able to talk to each other to make sure everyone's on the same page when this assay is introduced. And again, reiterating future application and thoughts, I can put a check mark. We've now, and Mindray has a cohort and demonstrated the URLs clearly demonstrate the IFCC guidelines for sex-specific cutoff. We have shown, and there's a paper that was just published in Clinical Chemistry Lab Medicine, there does not seem to be an interference of macrotroponin complex. We hopefully will be able, as I mentioned, discriminate hopefully between non-MI injury and also type 1, type 2. And this is where the potential for measuring immunoassays with different fragments, both troponin I and troponin T, looking at ratios to get a feel if we can differentiate different pathophysiologies. The future, I hope, will show that point-of-care assays will play a strong role in complementing the diagnostic role of the central laboratory. And I think in the future that Mindray is working on a troponin T assay, that they'll be able to examine it differently than the troponin T of Roche. And I know that hopefully will not show the false positive results that the Roche assay often pick up in neuromuscular disease. And most importantly, is in addition to the diagnostics, is the risk outcomes. Because one day, I think part of the electronic health record, we will be reporting risk assessment and hazard ratios or risk ratios to give a clinician powerful information on what type of triage and treatment that patients should receive. So again, I congratulate Mindray for a fantastic high-sensitive cardiac troponin I assay. And I personally look forward to seeing this assay rolled out in China and working and collaborating with other investigators in China to see how this powerful tool changes the practice patterns of clinicians across China. And I wish you all good luck. And again, thank you for the opportunity to present today.
Apart from conducting global research, we have also carried out extensive investigation in China. Now, join me as I take you on a tour of our research journey in Wuhan, China.
关于迈瑞的高密集格挡的性能确实我们前期非常荣幸的参与了他们大量的验证工作。总体来说，检测的性能和检测的实用性方面都是非常优越的。连续监测了180天，真实样本的1个 Ng 每升的总体的不精密度的 CV 值低至5%， 进行了11931个样本的抗感染检测，它的总体的检出率小于0.01%。
Now we know that Mindray offers a diverse range of high-quality cardiac biomarkers, including high-sensitivity cardiac troponin I, NT-proBNP, BNP, troponin I, CKMB, and MYO in the fields of chemiluminescent immunoassay. Moreover, we provide comprehensive solutions for cardiac health, spanning clinical chemistry and coagulation, in vitro diagnostic, as well as patient monitoring and life support and medical imaging solutions. Mindray remains committed to its visions of better healthcare for all by ensuring accessibility to high-quality products and solutions for more people. Our unwavering dedication is evident in the development of our comprehensive cardiac health solution. Through this innovative offering, we aspire to bring the benefit to our products and solutions to a larger population, positively impacting more lives.